So good morning. My name is Gerwin Huls, with my colleague.
I'm Dr. Valcárcel from Barcelona.
We would like to start this session. Please, Lionel, take the floor.
Good morning. First of all, I would like to thank Ariane and the organizing committee for inviting me to this meeting. It was a very exciting meeting, at least until now. So I will discuss the role of hypomethylating agents, venetoclax, and IDH inhibitors in high-risk MDS. This is my disclosure. So if you look, I like to start this presentation with this kind of slide. If you look at the ELN recommendation for the treatment of high-risk MDS that are published on the behalf of the ELN by Luca Malcovati more than 10 years ago, you can see that the treatment of high-risk MDS at that time relied mainly on azacitidine, hypomethylating agents, and stem cell transplant. And to be honest, this is still the case because we failed to get any approval for the treatment of high-risk MDS since then. But if you look at the NCCN guidelines, they are more innovative than the ELN guideline. And as you can see, this is the last version of those guidelines. Well, the treatment of high-risk MDS also rely on stem cell transplantation and hypomethylating agents, either azacitidine, decitabine, or the oral formulation of decitabine. But they also suggested that some drugs might be added to the backbone of hypomethylating agents, including BCL2 inhibitors and IDH1, IDH2 inhibitors. So is there any rationale to recommend the use of IDH inhibitors or BCL2 inhibitors in the field of high-risk MDS? And I will start with the role of BCL2 inhibitors for high-risk MDS. And you know that this has become the combination of the two drugs, and venetoclax has become the gold standard for the treatment of what we call unfit AML patient, based on this study that was published by Courtney Dinardo a few years ago in the New England Journal of Medicine, nicely showing that there was a survival advantage for patients treated with the combination compared to patients treated with hypomethylating agents alone. But can it be translated for patients with high-risk MDS remain unknown. Nevertheless, there are some studies that have been published suggesting that there might be a role for this combination. And I have highlighted here a study combining the two drugs, venetoclax and azacitidine, in a population of high-risk MDS, not as a first-line therapy, but for patients having failed or who are resistant to hypomethylating agents. Of course, it's a small study. As you can see, and as expected, most of the patients present myelosuppression, mainly febrile neutropenia, pneumonia, thrombocytopenia, and if the overall response rate was quite encouraging, 40%, only 6% of the patients achieved a complete remission. So as a second-line therapy, it might not be as good as we can expect for the treatment of high-risk MDS. Rami Kamroji from Moffitt took advantage of a small series of patients that have been treated in Tampa with the combination of venetoclax and azacitidine as the first-line therapy for high-risk MDS. And he compared those patients to patients who were treated at the same institution with only hypomethylating agents. And as you can see, I can't because I don't have my glasses. The overall response rate was significantly higher for patients treated with the combination, with more patients who achieved complete remission, 37% compared to 30%. But in this retrospective comparison with many bias, of course, there was no survival advantage for patients treated with the combination of the two drugs. What about first-line therapy? Well, recently in the Lancet Hematology, there was this very nice phase 1-2 study evaluating the role of venetoclax in combination with the oral formulation of decitabine in patients with high-risk MDS as a first-line therapy. As you can see, the complete remission rate was higher than one we can expect with hypomethylating agents alone, 44%, and half of the patients were bridged to transplant. So it's feasible, the results are quite encouraging, but is it better than oral decitabine alone? So to answer this question, they did perform a match pair analysis using a propensity score method, comparing patients who received decitabine to patients who received decitabine and venetoclax. And as you can see, the response rate was higher for the combination. There was no survival advantage, but still the event-free survival was significantly better for patients who received the combination of the two drugs. Once again, among the patients who received the combination of the two drugs, 47% of them did receive stem cell transplant, and this is quite high compared to what we have in the current practice usually. So is there a role for stem cell transplantation following Azacitidine therapy? We have little evidence for that, but a recent paper by the Spanish, published recently, few weeks ago, evaluated the role of stem cell transplantation following venetoclax and azacitidine in patients with high-risk MDS. 30 patients received a combination of the drugs. 23 proceed to stem cell transplantation either in complete remission or in response. And you can see the overall survival curve that was obtained with that strategy that is at least very encouraging. But for the moment, you know that venetoclax is not approved for the treatment of high-risk MDS, and we are waiting for the Verona results, the results of the Verona trial. In the meantime, the only result that we have combining hypomethylating agents and venetoclax is the phase 1b study evaluating this combination that was recently published by Jacqueline Garcia in Blood a few weeks ago. And to make a long story short, most of the patients experienced myelosuppression as expected. The combination is quite toxic, but the 30 days mortality was quite low, less than 5%, as it was for the 60-day mortality. So it's toxic, but it's feasible. And at the end, most of the patients achieved a response. 1/3 achieved a complete remission, and as depicted here, the median overall survival was 16 months. So those results are promising. We have to wait for the final analysis of the Verona trial to see whether, in a randomized manner, we can obtain better results than azacitidine alone when combining azacitidine to venetoclax. But for the moment, we have quite encouraging results, even if the toxicity profile of the combination is higher than azacitidine as a single agent. In the second part of my talk, I will discuss with you why in the NCCN guideline they might recommend the use of IDH inhibitors in combination with azacitidine for the treatment of high-risk MDS. You know that IDH1, IDH2 mutation are not that frequent in high-risk MDS, representing less than 10% of the patients, but still in EML, it's a very good target using IDH1 inhibitors or IDH2 inhibitors, either as a single agent or in combination with hypomethylating agents, and I will not discuss AML patients anymore. So what proved that we have that those drugs might be effective in high-risk MDS? Well, we have many. And this was the study that was published by Courtney DiNardo last year. This is a sub-study of a study evaluating ivosidenib in myeloid malignancies. And in that study, 18 patients had MDS. Most of them had low risk or high risk MDS. 31% had very high or high risk MDS according to IPSSR. But as you can see, in as a second-line therapy, the complete remission rate was almost 40%. That is quite encouraging. And the median duration of response was not rich. And as a second-line therapy, the median overall survival was quite nice, 36 months. So it's quite promising for a single-agent drug in this high-risk population having failed previous therapy. Another IDH inhibitor beyond ivosidenib is olutasidenib. And this study was published 2 years ago evaluating in AML and MDS this compound as a single agent or in combination with hypomethylating agents. And I just want to highlight that for patients who were treated with the combination of the two drugs, who were treatment naive, most of the patients achieved a complete remission that is quite encouraging for this kind of strategy. What about IDH2 inhibitor? A US study was once again by Courtney and Dinardo published 2 years ago, evaluating among 50 patients with IDH2 mutated MDS, either enazidenib as a single agent for patients having failed hypomethylating agents, or the combination of azacitidine and enazidenib for first-line therapy for patients with MDS. The toxicity profile is the usual one, the induction of myelosuppression with azacitidine mainly, differentiation syndromes, and that's it. This is the usual suspect with this type of compound. And if you look at the results in terms of response, as a first-line therapy, the overall response with the combination of the two drugs was 74%, and 1/4 of those patients achieved a complete remission. So it is promising, but what about survival? As a frontline therapy, the combination of enazidenib and azacitidine was able to reach a median overall survival of 26 months. And interestingly, as a single agent, enazidenib in a population with relapsed refractory MDS, the median overall survival was 20 months. This is quite high for this high-risk population. Briefly, I will present the two studies that have been conducted in France, led by Marie Seber for the GFM, evaluating either ivosidenib or enazidenib in low-risk, high-risk patients with either IDH1 mutation or IDH2 mutation, and the patients were either treated as a first-line therapy or as a second-line therapy. And all patients received ivosidenib or enazidenib as a single agent, and azacitidine, at least for high-risk MDS, was only added in the absence of response. Using enazidenib for high-risk population as a first-line therapy, 40% of the patients achieved a response, and the median duration of response for patients with high-risk MDS treated with a single agent enazidenib was 12 months. In terms of overall survival, we are interested in the yellow curve, patients with high-risk MDS treated with high-risk MDS treated with enazidenib as a single agent, and the yellow curve, you can see that the median overall survival for this high-risk population is higher than one we might expect if we compare with azacitidine alone, with a median overall survival of 25 months. What about ivosidenib? As a first-line therapy, the overall response rate was 78%, and 49% of the patients achieved a complete remission using ivosidenib as a single agent. And the duration of response for patients who were treated as a first-line therapy was quite nice. As you can see, the median overall survival and duration of response were not reached, with a median follow-up of more than 2 years. So to answer, to conclude on the role of IDH1 inhibitor in high-risk MDS, there is an ongoing trial called Pyramid that will evaluate the role of ivosidenib compared to azacitidine for patients with high-risk MDS, either low-risk or high-risk MDS. And this trial is ongoing in the US and in Europe. Finally, at least in AML, there are a lot of discussion about triplets. So in MDS, we don't have any doublet for the moment, but what about triplet? There was this interesting study presented at last ASH meeting evaluating the combination of azacitidine, venetoclax, and ivosidenib in AML or in MDS. And as you can see in newly diagnosed MDS, the response rate was quite interesting, whether we might have any future for a triplet combination in high-risk MDS, I don't know, but this is important to highlight this kind of information. So I'm a little bit beyond schedule. IDH inhibitors are quite effective in patients with high-risk MDS, giving as a single agent encouraging results and challenging the role of azacitidine as a single agent among those patients. Maybe the combination of the two is better than IDH inhibitor as a single agent, I don't know. There are great hope for the role of venetoclax in high-risk MDS despite significant myelosuppression, and very nice results are eagerly awaited. So I would like to thank you for your attention. This is all the people. I would like to thank the people from my institution, from the GFM, from the EMSCO, all the patient and the family who were enrolled in the study that I've presented, and thank you for your attention. Happy to take any question.
Thank you, Lionel, for an excellent talk. Are there questions? Please.
Yes, thank you, Lionel, for the very good overview. I have one question. If we are facing IDH inhibitors, is it clear what the WAF means in relation to response? Because one could argue that if the WAF is low, it is only a side branch of the clone, and so you cannot expect a real good therapeutic efficacy.
Thank you, Dr. Well, at least in AML, what we know that the response rate is independent of the size of the clone. And this is probably, even if the proof are quite not straightforward, that there is a paracrine effect of the UAG that might be bypassed by ivosidenib or enazidenib. I'm not sure that in MDS, the picture is totally similar. And it seems, at least in IDH2 inhibitor trial that we conducted with Marie Seber, that the size of the clone matters in terms of response. So for the moment, this is preliminary data, but the picture might be different in MDS and in AML.
Thank you.
So if I may ask you a question. So we discussed the classifications yesterday, and there's a lot of discussion that maybe high-risk MDS is kind of AML, and we should lump them together a little bit. But if you see the data from these combinatorial treatments, it's not that easy, I think. So what's your perspective on that?
Well, I will start by saying that I don't think that high-risk MDS mimic AML or belong to AML. I think that there are a lot of AML that are MDS. So this is the opposite. But what is important is to find parameters that might predict response to either therapy, either for AML or MDS. For the moment, at least with azacitidine, we have failed to identify solid parameters that might help us to guide what patient should receive azacitidine. And the question was not that important because we had only one drug. Nowadays, it might be of importance to have parameters that might help us to guide what patient should be treated with the combination of the two or azacitidine alone, if there is still a role for azacitidine alone, I don't know, irrespective of the diagnosis of AML or MDS. You know that there are data, at least in AML, but also in MDS, that suggests that I6L1 is indicative for a better response to venetoclax, whether it will be a hallmark marker of sensitivity to venetoclax and might help us to decide whether this patient with high-risk MDS or AML should be treated with the combination of the two. I don't know, but I hope we are going into that direction.
Okay, thank you. If there are no more questions, then sorry.
Lionel, one brief question. Also, we need to wait for Verona data, of course, but you show some data. And it looks like there is no doubt that complete response is probably better with the combination. Some doubts regarding overall survival, except in those studies that included allogeneic stem cell transplantation. So do you see this, and while we wait for final results, of course, but do you see this combination as a bridge to transplant or as initial step and then following with only monotherapy? I don't know.
Of course, the politically correct answer is wait for the Verona trial, but...
I'm not waiting that for you.
But most of the people in the room are already treating their patient with the combination of the two because of the reason you said, because you can achieve very good marrow response, complete remission. As a bridge to transplant, it can be obtained easily in a timely manner to perform stem cell transplant. So if the results of Verona will be negative, I don't know, but it will not change the picture of the treatment of high-risk MDS. But it will be easier to build on something for the future trial. Because if the drug is not approved, and if we use it on daily basis, what will be the next trial for high-risk MDS? Are we going to build on azacitidine and using azacitidine and venetoclax in our clinic, but not be able to build a clinical trial, the combination of the two, because it's not approved? It will be insane. So,
Okay. Thank you, Lionel.
thank you.
So then we move on to the next speaker, is Dr. Sallman from Moffitt Cancer Center in Florida, immune modulation and immunotherapy in MDS.
Perfect. Thank you, chairs, for the introduction, and to the organizers for inviting me to this beautiful meeting. It's really my favorite meeting. It almost always happens on my birthday as well, so I always look forward to coming. Thank you. These are my disclosures. So there's really a lot to cover. I think this talk could go a lot of different ways. I'm really going to focus more in the high-risk setting and not go into a lot of detail on sort of the existing data. I'll highlight a little bit on how we work to try to activate innate immune system, what we've been doing in adaptive immune system, and potentially what is the path forward, is it cellular therapy, et cetera, with, again, some learning points as we go. So again, briefly, we'll sort of start in the anti-CD47 space with magrolimab. And just one comment is that it takes time to really get optimal response. This is somewhat expected from IO-based therapy. And although hematopoietic improvements could happen early on, our median time to really optimal CR was between like the 4 to 6 cycles. And we had actually true CR patients, including conversion to MRD negativity states, as far out as 9 cycles. And I think this is one challenge, as when we went to the phase 3 experience, a lot of patients unfortunately had very short therapy out of some on-target toxicity. And I think we heard really nicely in the last talk, again, really optimizing how patients can do with transplant. I think maybe before some novel therapies, could transplant utilization be decreasing over time? I think if really anything, it's increasing. And again, over 30% of patients being transplanted in the phase 1 study, and again, survival of 70%. And these data held up with longer follow-up from that perspective. Now, potentially with IO-based therapy, can we get deeper responses? I think deeper responses we know can translate to improved outcomes, again, mostly in acute myeloid leukemia. But I think we've heard several nice talks, again, both considering flow as well as molecular MRD evaluations. And now even in the setting of prospective trials, we can see that, again, this is using the main central lab in the US for MRD flow cytometry. Patients that achieved MRD negativity clearly had improved outcomes. I would say this also held up in the phase 3. These data are going to be in press in the near future. And even in patients that had azacitidine monotherapy, again, achievement of MRD negativity by flow in MDS was of prognostic relevance. So this led to, again, the ENHANCE trial, again, one of the 2 largest phase 3 trials, conducted to date, over 500 patients, international collaboration. But just want to highlight maybe some key challenges. And again, I'm very, very much hoping that Verona is positive. As Lionel has said, again, what do we do if it's negative is a big challenge. But we really have to think a lot more carefully about how we balance and stratify these trials. Again, these sort of arbitrary divides based on blast count and let's say cytogenetic or IPSS-R risk are not enough. So actually, the disposition to me is maybe one of the more important things to glean from this study. So 32% of patients in the azacitidine control arm were bridged to stem cell transplantation. I'm going to contrast this versus savatolimab in a moment. And even at baseline, when investigators assess, is my patient potentially a transplant candidate, again, this was not a stratification factor, you can see there's a 10% imbalance in the placebo arm. Another key issue is P53. I think we all know that this patient needs to either be its own trial or essentially a required stratification factor. There was an imbalance, and in this trial, actually, even though we were excited based on early activity in P53, where responses are probably not the optimal endpoint, there was actually a doubling of CR, unfortunately, in the placebo arm in P53 mutant patients. This is actually mostly what skewed, again, unfortunately, a very negative trial. These are what the data are. Again, I think the P53 subset is key, and then really, I think separately, that impact of transplant is really what drives this amongst some early toxicity, again, related to the on-target anemia that was recognized, but even with changes in transfusion thresholds, was really too late in the study, and again, many patients came off early. There was the ENHANCE-2 trial. Again, these data are impressed, not to go into detail, but we can run pivotal frontline P53 trials in actually an expedited fashion. So what other therapies have been targeting this axis? Again, this is a novel bifunctional fusion protein that not only inhibits the CD47 axis, but also has a CD40 ligand agonist to potentially augment antigen processing, potentially crosstalk and get increased adaptive immunity. Again, relatively limited activity as single agent, but there was combination, and again, based on potentially this role in P53 and the fact that HMA venetoclax has not improved outcomes in that group, we sort of ran an expansion cohort, again, presented at IDHi. Now, the responses were quite reasonable. We actually saw quite a bit of molecular and MRD flow conversions, but the durability, unfortunately, really hasn't held up. The 60-day mortality was high, and this is a repeating issue. Actually, ENHANCE-2 and AZA-VEN, the 60-day mortality was also 25%. Again, this is a big challenge as we're rolling out. And then unfortunately, we ended up closing down this agent based on not a clear efficacy signal. So really the last CD47 therapy that is in, I would say, more advanced development currently is AK117 or ligafulimab. This is data that's been predominantly out of China, but has now entered the US. And it does have a nice aspect from a toxicity perspective in that it does not cause any RBC agglutination. This has to do with differential structure in the antibody. So essentially, they can't cross-link multiple red blood cells as AK117 through both motifs by singular red blood cell. The CD47 receptor occupancy data are quite good, and the CR rate was actually highest to date, I would say, in a relatively comparison cohorts versus other CD47 agents. So this trial is actually, I think, nearly completed accrual in this randomized phase 2 trial. Again, looking at 2 dose levels of AK117 versus a placebo arm. Of course, what are the next steps based on Verona? I think that's going to significantly impact, but we should see these data at an upcoming Congress. So what about targeting TIM3? Again, these data were presented by Amer Zeidan, who's here. Again, another over 500 patient trial. And again, really just to speak about the imbalance of transplant. So this is the exact same group of patients. You could actually argue slightly less sick in this cohort, and now 8% of patients in the transplant. So 32% versus 8. What's the difference? These imbalances are having huge implications in how our patients, or how these trials may ultimately read out. Again, what's the difference with Viali? Viali had 3 patients that were transplanted. So the overall survival, again, this was very close to significant. Now, interesting enough, the survival curve separated early, not late, which is potentially what some were thinking on earlier studies. The CR rate was not advanced. But again, were there subgroups of patients that may have best been targeted by this therapy? Again, hopefully a lot more translational data could potentially build out as samples were serially collected on this study. Now, I think what was really nice, just kind of speaking to sort of the biological rationale, is galactin-9, which is the ligand of TIM3 forwarding this autocrine loop to stimulate leukemic stem cell propagation, was actually prognostically significant. This was agnostic to treatment. And I think nicely also IPSSM validated in a large prospective trial as far as outcomes. So what can we do? I think one of the best things about ICC is, at least now, a lot of companies are willing to play somewhat in the MDS space, although I think we're a little bit of the orphan stepchild from that perspective. So a lot of traditional targets, again, mostly have been preclinical CAR reports, but we are starting to see really some finalized publications. The number of MDS patients treated in the world is tiny. I'll highlight a couple of our experiences. So this was our NKG2D CAR. Again, the data were published. Again, if you squint really in a challenging way, you can see the one MDS patient that was here. The patient did have a blast clearance, but the response was relatively not durable, which was really a challenge with the NKG2D CAR, and this has been abandoned. Now, we have an ongoing autologous CD33 CAR, where, again, this is a rapid manufacturing, not traditional viral vector system, again, targeting CD33. And again, this trial is going to be expanded in a focused group in AML patients. But we did allow both MDS and CMML. You could see small numbers, but for what it's worth, we did not have any responses. And I think it speaks, what is the differential T cell function in these patients versus AML? Is this going to be a challenge, let's say, in the autologous world for cellular therapy, but hopefully we can have more trials, at least from a biological perspective. These patients are not hyperproliferative and are quite reasonable to potentially target with ongoing trials. Now, there's a lot of challenges in AML development. There's there's issues with very much heterogeneous antigen. There's antigen sink issues. There's issues, do patients have to go to transplant? There's a lot of microenvironment issues. There's even issues with how do we call response, et cetera. So there's this Impact AML group, some multi-institutional international collaboration led by the group at the bottom, where we're trying to harmonize these standards. There's going to be a consensus paper in the near future around some of this as well. So moving on, again, if I'm giving a talk, I at least have to talk about P53, even though it has nothing specifically to do with the title of the presentation. And we heard a lot of beautiful presentations. And I think, although it's quite critical talking about allelic state, et cetera, really there's this strong overlap between karyotype, blast increase, the VAF. Again, are these patients multi-hit? And I'd just like to point you to this really nice publication. This just came out a couple of weeks ago, led by the Mayo Group in collaborations with the Australian group. And it's quite simplistic, which is nice. And if you take every P53 mutant patient, this is a large cohort of 600-700 patients between these centers, 91% of patients are the adverse risk group. So is it important to help stratify patients? But yet we're talking a lot about a very, very small percentage. You could see the outcomes on the bottom based on these subdivisions. And again, sometimes we're talking about what is the difference between terrible and horrible. So why do I bring up this group? I think nobody would argue that this is the molecular subset that most urgently needs novel therapies. And this is a biological group that has such a profound difference from an immune microenvironment perspective. So again, if you look at, for example, PD-L1, it's significantly upregulated on leukemic stem cells of P53 mutant versus wild type patients. This was seen both in our data as well as a similar publication out of the MD Anderson group. And what drives this? So in collaboration with Ben Ebert, using his CRISPR missense knock-in cell lines, essentially with the presence of mutation, you get MYC overexpression, which is a known regulator of PD-L1. And we did a nanostring microRNA panel, and the only microRNA to be significantly downregulated in the mutant versus wild type was miR34A, again, another known regulator. So you have this driver on the leukemic stem cell itself. And then separately, you get these extreme immune adverse, sort of signature. And we see this infiltration of this highly immunosuppressive Treg population. Actually, if you look at any activation or inhibitory, pretty much it's all the opposite way of what you would like it from an adaptive immune response in these patients. And I think speaking more to this, and there's really eloquent publication recently published led by the Della Porta group at International Collaboration, kind of drives a lot of this in. They see this MYC overexpression. They see an impairment of antigen presentation. And again, sort of every adverse immune feature that you want to see, and again, a highly inflammatory microenvironment as well, is in P53 mutant patients. Now, what was nice in this publication is they also identified this quite small group, about 5% of patients, that have a hyperexpression of normal P53 protein. Some of this is through MDM2, MDMX overexpression. And this group was essentially identical, so maybe another subset of patients to kind of potentially lump in. Now, speaking to sort of the end product of this. So this is a really nice single-cell cytokine analysis looking at the polyfunctionality of T cells. Now, this was an AML-based study, but I think what's striking is, of course, in relapsed refractory disease, everybody knows that the T cells are significantly impacted. But if you look even at baseline, the patients that have the presence of P53 mutation were essentially the same as any patient that was relapsed. So again, maybe autologous CAR is not the answer given all of these challenges. Maybe allo CAR could be the answer. But even there we have challenges. So this is by a group in Zurich. Again, using this sort of same system in the animal model, looking at, again, the activity of AlloCAR in patients with or without the presence of P53 mutation. And what they were able to see is that in the presence of P53 mutation, you get this prolongation of forming the actual synapse between the lymphocyte and target cell, and this actually led to an outgrowth of the disease. Now, notably, this was dependent on the mevalonate pathway, and so essentially maybe we could add statins to AlloCAR to be our answer. So what is coming? Again, I alluded to this at the beginning. I think one nice thing of sort of this joint MDS AML is a lot of first-in-human phase 1 trials are at least considering MDS. This is one trial that I think is quite exciting, going to be entering the clinic a little bit later this year, called Crosscheck 101. This is a T-cell engager that targets cathepsin G. Cathepsin G is normally only expressed in neutrophil granules, but in myeloid malignancies is extracellularly expressed. Again, this trial is happening. It is HLA-A*02:01 restricted, so again, would be only a subset of patients. But I think the challenge is we really may need to think out of the box. Maybe, combinatorial CAR targeting multiple antigens, but we may also need combinatorial approaches to really best augment our immune system. So STING agonists, which I think actually are a very interesting agent. Again, this is data largely out of Australia that may be able to kill in sort of a P53 independent fashion. But very nice work by Marion Seclou is able to show that STING agonists could potentially augment T-cell engagers. This was at least in the setting of a CD33 bispecific agent with really a profound synergy. And then potentially venetoclax. Again, this may be optimal bridging or cytoreduction type therapy, but it can also synergize from a immune therapy perspective, actually in a number of models. And what's nice, it's really net neutral sort of on T-cell function, actually may deplete dysfunctional B cells separately, which was shown in this publication. And so maybe one of the key things, and I think what's lacking is as we jump from phase 1 to phase 3 trials, is a lack of key translational data. And can we, as an international group, really build optimal panels? Can we centralize this, perform really the best studies to characterize the immune microenvironment, both at baseline and sequentially? And a really amazing initiative by Shoreham Kardasti started with many members in this group is this I4MDS, or sort of a consensus paper on panels. And I'm hoping this group can really be directly integrated into future IO-type strategies to best optimize how these trials are run. And with that, thank you for listening and happy to take questions. Thank you.
Thank you, David, for a very nice talk. Are there questions? If not, I would like to start. Also, the whole magrolimab story is kind of disappointing. And now there are new anti-CD47 blocking antibodies and SERP blocking antibodies developed. But if you think about it, and I think we all learned at medical school that you need to opsonization, and then the phagocytosis will occur, and then maybe checkpoints will control that. So did pharma or did we design these trials in the wrong way? So should there be should there be a first signal? Should there be an antibody, an anti-CD33 antibody, and then come in with your blocking antibody to push them over the bridge, basically?
Yeah, I think it's a great question. I mean, I think there's no question that you need to have that augmentation of a prophagocytic signal. Again, azacitidine, challenging, upregulates everything. So did upregulate, calreticulin, and that was really most of the sort of preclinical rationale. But there were, a number of strategies. The first study was really with rituximab, where rituximab could be, basically that factor to then target the B cell. And so we had discussed doing this, let's say, with CD33, 123 targeting. Some of the challenges is that most of these get internalized, and that's not the best factor from that perspective. But I do think, let's say with AK117, what happens in the randomized trial, it's a good question whether or not we could try to further push that balance and get more activation of phagocytosis. There's some very interesting work out of the Dana-Farber group that sort of is maybe questioning exactly how anti-CD47 therapy has a role. I think those data are going to emerge that may help shed light on some of this as well.
Thank you.
Yeah, nice talk, David. In your observations about the transplant between the magrolimab phase 3 and the sabatolimab, so as you mentioned, the sabatolimab had 10%, but the phase 3 primarily enrolled ex-US. I think the number of patients enrolled in the US was very minimal. I don't know what with the phase 3 in magrolimab, but my sense is that it enrolled more patients in the US. So do you think, I can't recall how many patients went to the phase 3 in magrolimab to transplant, but do you think this is driven by where the patients go. The reason I bring this up is because we always have this discussion about is bridging someone to transplant and should be an endpoint. I mean, my view has been always it should not be, because depending on your transplanter, they can transplant any patient they want, So I think what happens post-transplant, and building on this question, and I think you alluded to this a little bit, but for patients who actually did go to transplant, do you see any difference based on your phase 1 data?
Yeah, so good question. As far as the exact distribution, I think it was relatively equal U.S. and ex-U.S. It's a good question that we definitely can look at the data. I definitely haven't seen them yet, whether or not there was any imbalances as far as transplant frequency, U.S. centers versus ex-U.S. centers. I mean, there's no question actually a lot of the difference from the survival is patients that were transplanted did by far better. Again, that's not shocking from that perspective. I think the question, we very much know that HMA therapy pre-allo has not done anything. I think the challenge is with more optimal combinations in getting, let's say, MRD negativity, deeper responses, I think is this change, because in AML it clearly is dramatically impactful in patients that get optimal responses pre-allo. So I think we need to be, at least, obviously we're going to see what happens with HMA-VEN. That to me is the most critical subset analysis, although kind of conflicting data if you look at everybody's cohort from that perspective.
Thank you.
Okay, last question. Yes, please.
Thank you very much, David, for excellent overview. My question is, or maybe comment, is about the checkpoint inhibitor. When we talk about it, it's most of the trial patients are from higher risk, and as you mentioned, the remodeling happened, the immunosuppression kick in P53, we show the same thing. Do you think maybe in the future, when we want to potentially try again with combination, we should maybe include more of the earlier stage before the remodeling happens, and maybe that's one of the reasons a lot of these trials are failing, because we are not really going early enough?
I think it's a great question. Definitely, we know that as time goes on and patients do progress, over time, that we have a more negative immune microenvironment from that perspective. I think there's logistical challenges like on how you design these trials, right? In low risk, we have to only treat anemia and go for transfusion independence. But I think to your point, can we think about disease modification, and would some of these things make more sense? Again, speaking to hopefully the goal of some of this I4MDS initiative is maybe we can have smarter, earlier randomized phase 2 trials, really try to truly understand, because we don't. We look at patients at time of complete remission, we say, oh, look at all of these, advantageous changes that occur, but what's really happening that's differential with combination versus like monotherapy, I think we need to evaluate it, but I think it's an excellent point. Should we think about some of this? I think we are going for that in sort of the inflammasome targeted based therapy, but it's a good, whether or not we need to target that with some sort of immune activators at the same time, I think are questions. I have some concern about monotherapy in that setting as well.
Thank you very much, David. We are moving to the next talk, allogeneic stem cell transplantation, and it's Dr. Bart L from Fred Hutch in USA.
Hello, everyone. I'd like to thank the organizers for inviting me to give this talk on higher risk MDS. These are pictures of my institution. I kind of like to joke that they're kind of fake, because it doesn't really always look like that in Seattle, and they moved the mountain around. So if you're actually from Seattle, you know that this is fake photography. I'm here today to speak to you about transplant for high-risk MDS, and I call this my job security slide. And as you can see, transplant activity has been increasing in the United States for a variety of different diseases, but primarily for AML and MDS. So I've got at least another good 10 or 15 years left before the previous speakers discover another cure for MDS. And it should be pointed out that allogeneic transplantation is the single most potent anti-myeloid therapy that we have available to us, and is the only intervention to date that's been shown to be curative for MDS. But it has a high treatment-related mortality. And so there's always been this question of who should get it. And that's been a changing dynamic over the years, and I'm going to review best available data that we currently have. First, let me just say that age alone is not a contraindication to allogeneic stem cell transplantation, but it is certainly a consideration. And when we evaluate a patient for transplant, we use what's called the HCT-CI, also known as the Soror score, which was developed by Mohammed Soror at our institute. But we also use the CHARM score, which is the most recent one that looks at a variety of different issues, including the HCT-CI. And that helps us to predict for a given individual what their potential treatment-related mortality is. This is a prospective study from the CIBMTR. It's called the Medicare Coverage Decision Model, but it prospectively enrolled patients into a coverage analysis. And you can see that the way they looked at this data, there was really no impact of age on transplant outcomes in patients with MDS. But there are some criticisms, and most notably, the age was really concentrated around 65 to 66. And age is not a binomial variable, it's a continuous variable. So I don't think you should look at this and say age doesn't impact transplant outcomes. But what we should do is say, for given individuals who are over age 65, they may still be suitable for transplant if they have low comorbidities. In regards to disease severity, there have been 3 donor versus no donor studies. We call them biological assignment trials. They're not really randomized studies, okay? But they are a donor versus no donor, and they have a lot of similar characteristics and some pitfalls as well. One of those pitfalls is that all of these donor versus no donor studies used older prognostic algorithms, the IPSS, and of course that's not what really we're using right now. Another criticism is that they all use kind of different conditioning regimens, and another criticism is that they all use different ways of preparing the patients for transplant. This was the first one, it's from the GFM group, and they looked at no donor versus HLA matched donors, and they showed a significant impact in overall survival. This curve is telling because the curves don't start to separate until 2 years. And you're gonna see that repeated over and over again in all of the donor versus no donor studies. So that's useful for counseling. If you're seeing a patient whose anticipated survival is less than 2 years for other reasons, they probably shouldn't be exposing themselves to an allogeneic transplant because the survival benefit is not expected until after 2 years. Another thing to say about these curves is that these are not proportional hazard models like what you're used to. These are point-wise comparisons. When you have risk exposure that's not proportional over time, the proportional hazard models will not hold. And when you do a donor versus no donor study, you expose people to increased risk of death early, but benefit later. And in the no donor group, they're not gonna have that early risk of mortality, which is why you need to do these point-wise comparisons because the Cox proportional hazard models would not hold. This gave a RIC regimen of 2-day busulfan, and the eligibility was 50 to 70 years, and patients were eligible if they had intermediate 2 or high-risk disease, or intermediate 1 with low platelets or poor-risk cyto. The Videza Allo study done by Dr. Kroger was another donor versus no donor study. An interesting aspect of this donor versus no donor study is that they had a 4-dose run-in or 4-month run-in with Videza. So patients got some cytoreductive treatment. It was underpowered. The primary endpoint was 3-year overall survival, and the study was stopped early. The conditioning regimens that these patients received was also reduced intensity conditioning, Flamza or 2-day busulfan. One of the things that Dr. Kroger pointed out in his talk is that they did lose a lot of patients during this 4-month run-in with Videza, which has led some people to question the potential benefit of giving cytoreductive treatment before allogeneic transplant. I would caution you from using this data to make that assessment because it may be the patients who failed AZA would not have benefited from allogeneic transplant anyway. So this was not, a study designed to answer the question of pre-transplant cytoreductive treatment. This curve also demonstrates the issue with Cox proportional hazard models. You can see that there's an earlier mortality rate in the transplant arm and a later mortality rate in the non-transplant arm, which is exactly what you would expect. And so when the curves cross, of course, you can't use the Cox proportional hazard. Like many of these donor versus no donor studies, it was intent to treat, and a lot of the donors, of course, don't always go to transplant, and a lot of the no donors do go to transplant. And 14 patients in the continued AZA arm in this study did receive transplant after progression. There was not a statistical difference, but the point estimates did favor allogeneic transplant in this study. And then, of course, we also have the CTN 1102 study, a similar design. Here, they didn't dictate a 4-month run-in with pre-transplant therapy. It was a larger study. It completed a full accrual, and you can see it was intent to treat, and some of the people actually didn't receive the intervention that they were planned to get. There was a 21.3% improvement in survival if you had a donor. They also did a sensitivity analysis. This is because in order to find out if you have a donor, you have to be alive long enough to find out if you have a donor. So you want to correct for time, and even when you did that, there was still a benefit with allogeneic transplant. So that's kind of led to this idea that patients with higher risk should get a transplant if they can. But of course, this used old stratification systems, prognostic systems, I should say. And we all know that mutational analysis are very important. Some people have used this data with the very poor outcomes with P53 that you see, let's see, here, to say that P53 mutated MDS patients should not undergo allogeneic transplant. I don't agree with that. I was kind of joking around with some colleagues that yesterday I had to argue no, but I didn't pick no. They gave me no. But this is really good data from the donor versus no donor study showing a benefit with transplant even in mutated P53. Now, okay, it's not great. Nobody would want to be on either one of these curves, okay? But if you had to pick a curve that you wanted to be on, you'd pick the blue one. And I always like to say to my chemotherapy colleagues, what great stuff do you have for mutated P53? And the answer is nothing. So if you want to live and you have mutated P53 MDS, you should go to transplant. That's an opinion. All right, I mentioned to you one of the limitations on the donor versus no donor study is that they used the old IPSS, and now, of course, we're all using the IPSSM. So this is a really fantastic study looking at 7,118 patients. That is amazing. I don't know how they got all those patients together. They all had primary MDS with WHO 2016. They all were over age 18, and of course they had the IPSS-M variables. And what they showed is that there was a benefit with allogeneic transplant for patients who had high and very high-risk disease, and also for the older people for moderate high, but not for patients who had low or moderately low disease. So that's what we're using now. I should caution you, these Markov decision models have a lot of limitations. They assume a stochastic process. Stochastic is derived from the Greek word meaning stakos. That means to aim at and guess, so you should know that. The other thing is that these assume that it's a random process, and biological processes are not random. And it also assumes that prior states do not predict future states, and that's not a true statement from a biological process. For P53, if you have mutated P53, this is a subset from the same study, you should really go to transplant. If you fail AZA, this was brought up in the prior session, with high-risk disease, transplant is the only potential curative option and results in the best outcomes. I admit this is retrospective, so there's a huge selection bias, but also similar things with low-risk disease has been shown. Again, retrospective selection bias. In the US, we're now under this Medicare coverage decision model, and you can see that we can only offer patients transplant if they have intermediate 2 or high-risk disease by IPSS or high or very high. This is very limiting to us. It doesn't take into account P53. I checked on the IPSSM calculator. You can still be in the lower risk categories with a single mutated P53 allele with a VAF of 12%. That's what I put in. With a normal karyotype, I have to say. I did put in the normal karyotype. But anyway, there are some patients who should go to transplant that aren't under this Medicare coverage decision model, which includes low-risk patients who progress. A controversial topic is who should get pre-transplant therapy. A lot of retrospective studies have been done, but retrospective studies have selection bias. I did want to review this data pretty quickly because I think it's the most powerful data that we have to date. But it looks at 1,482 MDS patients from the EBMT database. You can see that most people got a RIC regimen, but there was no benefit in giving therapy before transplant, whether you had the same state in IPSS, whether your IPSS was improving, or whether it was progressive. So no benefit with giving cytoreductive treatment in overall survival or progression-free survival. The type of cytoreductive treatment did matter. It seems like induction chemotherapy did better if you were improving. Interestingly, if you gave HMA before transplant and you improved the MDS disease, there was still no benefit in survival following allogeneic transplant. Switching gears to pre-transplant conditioning. The purpose of conditioning is twofold. It's to facilitate donor cell engraftment and also to potentially reduce the risk of relapse. With higher toxicity, with higher intensity though, comes higher toxicity. So there's always been this question of, should patients get more intensive regimens? And there have been 3 large randomized trials that have been conducted to date, unfortunately showing slightly different things and including different patient populations. But they do have some things in common. This is the RIC versus MAC study in AML CR1. It was a German study, and basically they showed no difference between ablative and reduced intensity conditioning. This is the MAVERICK study, which was a long-term follow-up now and published in 2021, which did show a benefit with myeloablative conditioning. And this is data from Dr. Kroger, who looked at the EBMT RIC-MAC trial, which showed basically similar outcomes between reduced intensity conditioning and myeloablative conditioning. I like to think of conditioning now as more of a continuous model, and I think we need to move past these old definitions of RIC versus MAC. And I think right now we're actually in the era of choosing conditioning based on an individual patient, rather than trying to make a decision more broadly. This is a retrospective comparison of melphalan versus busulfan, showing disease-free survival that was improved with melphalan. I think fludarabine and melphalan is the most common conditioning regimen that's used in the United States for patients who get a RIC regimen. That's in contrast to probably what the European colleagues do. They're more likely to give treosulfan. This is a subset analysis of a non-inferiority study comparing treosulfan to 2-day busulfan. And this study did show that treosulfan was non-inferior to 2-day busulfan. And that was based on a 2-year event-free survival. This is a subset analysis specifically looking at MDS patients, which showed an improved event-free survival with treosulfan compared to 2-day busulfan. This is a large retrospective comparison of conditioning intensity from the CIBMTR that included 951 MDS patients and 1,258 AML patients. This is one of the largest retrospective studies looking at conditioning intensity, but basically it showed that the relapse risk was less with a fludarabine melphalan-based regimen compared to other reduced intensity conditioning regimens. You won't see treosulfan on here because patients weren't getting it at the time. So fortunately, I've reached my summary slide, which is good because I've gone over a bit. But in regards to who should be transplanted for MDS, I say moderate, high, and very high risk by the IPSSM. I think if you have low-risk disease and you fail other therapies, particularly AZA, you should go to transplant. Should you get pre-transplant therapy? It's controversial. Our current practice is yes, if it's a reduced intensity conditioning regimen and patients have more than 10% blast. But if they can get an ablative regimen and they have less than 10% blast, no. If patients are getting Flu-Mel and they have less than 10% blast, no. If patients are getting our very low intensity regimen, which is 2-grade TBI, they really need to be in a morphologic remission for that. And then the RIC versus MAC is kind of an old analysis, I think, and I think conditioning intensity should be based on a given individual. So with that, I'll bring this to a close. I'd like to thank you all for your attention. I know it was really quick. I'm happy to take any questions if there's time for that. Thank you. Yes, Amer.
Bart, 2 questions actually, and they probably are more related to policy rather than the kind of the science. But in the US, you mentioned that, I think lower risk, in my opinion, has been always a misnomer, right? Because those patients will die from MDS. It's just a matter of how much time do they stay in lower risk. And we know that most lower risk patients technically do not become high risk by the criteria. And now with this new rule by CMS, we are having trouble kind of getting our transplanters to, or they cannot get the authorization to transplant patients who have low risk, who are either HMA failure or very close to failure, but they should be transplanted. So how do we get around this? And the second question, also somewhat policy related with the TB53 patient, and I fully agree with you that those patients should be transplanted because I would take 20% over zero. But the question, I think, again, is how transplant is in the US, and I think in other countries, again, publicly reported, people care about their outcomes because they don't want insurance not to reimburse them, and people don't want to come there, so they don't want to transplant high-risk patients. So how do you get around this?
Yeah. So for the first question, I happen to be the chair of the ASH Government Affairs Committee. We are working with Medicare coverage decision to try to get those decisions changed. Corey Cutler has been involved with that as well as the practice committee, which Dr. Percival is the chair of. So ASH is definitely working on that to try to get this Medicare coverage decision model changed, because I agree with you, there are low-risk patients who should be allowed to go to stem cell transplant. And then the second part of the question was mutated P53. Yes, I hear it all the time. Well, how do we get around this? Have meetings like this where we get up here and we kind of say to our colleagues, look, mutated P53, go to transplant. It's the only thing that's going to allow you to live. But I agree with you. There's even at the Fred Hutch, there's a lot of my colleagues who don't want to transplant P53. And I'm like, look, if we don't transplant them, they're going to die. Which is true for many of the things that we transplant people for.
Thank you.
Yes.
We have another question there.
Can you describe the specificity of this very, very high-risk MDS patients in post-transplant management? Because I think that it is the topic you have not mentioned.
That is correct. I wish I could have a lot more time to speak, but I can't speak about everything. Prevention of post-transplant relapse is certainly an issue. Relapse is the most common reason why allogeneic transplantation fails, not graft versus host disease. Seems like everybody cares about GVHD these days. So it's conflicting data, and I wish I had time to go into it to great detail. But for mutated P53, we give them a maintenance strategy, even if they have no evidence of disease at time of transplant. And typically that would be with hypomethylating agents. We also have prophylactic DLI infusions that we would give if we follow mutated P53 post. And if we see that their VAF is coming in or increasing, then we would add DLI to that maintenance AZA regimen. But that's what we're doing currently. And try to enroll them into a maintenance strategy post-trial. Just like with the Verona trial, we're all waiting on Viali-T, and that's giving AZA venetoclax post-transplant. That data is out there as well.
So thank you very much, Bart. We are perfectly on time, so we move on with the next talk, Despoina Dimitriou, regarding the role for ADAR1 in resistance to hypomethylating agents in high-risk MDS. Thank you very much.
Hello, good morning, everyone. My name is Despoina Dimitriou, and I'm a PhD student from Dimokritos University of Thrace in Greece. I'm very honored to present you our research today on the role of ADAR1 in resistance to hypomethylating agents in high-risk myelodysplastic syndromes. I have nothing to disclose. So, recent data on cancer cell lines have shown that HMA trigger a viral mimicry response by reactivating the human endogenous retroelements. Nevertheless, this antiviral response was neither correlated nor predictive of the clinical response to HMA when we examined it in primary hematopoietic stem cells in collaboration with Professor Kassiotis from Francis Crick Institute. Medipur et al. Recently showed that adenosine deaminase acting on RNA1, also known as ADAR1 enzyme, restricts HMA-induced interferon response in human cancer cell lines. The ADAR1 enzyme destabilizes dsRNAs derived from inverted allo elements, IR-allos, by catalyzing the deamination of adenosine to inosine, a process called A2I RNA editing. and thus represses the interferon-dependent anti-tumor response. A2I RNA editing has reported as a crucial mechanism in cancer biology, and ADAR1 emerges as an important determinant of resistance to immune checkpoint therapy. So, collectively, the above data suggest that the differential expression of ADAR1 enzyme may account for the disconnection between the clinical response and the induction of viral mimicry we observed in our study. Based on these considerations, we propose an updated model of the viral mimicry hypothesis implicating ADAR1. Another emerging area of interest involves the interplay between interleukin-6 signaling, STAT3 activation, and ADAR1. This axis functions as a positive regulatory loop in which the activation of receptor of interleukin-6 leads to the phosphorylation and activation of STAT3, which then promotes the expression of ADAR1 P150. This isoform, in turn, enhances STAT3 activity, creating a feed-forward loop that amplifies oncogenic signaling and contributes to the progression of multiple myeloma. Furthermore, ADAR1 seems to promote the expression of STAT3B isoform during the progression from pre-leukemic to leukemic cells. Previous findings from our group have shown that azacitidine can restore dysregulated STAT signaling in high-risk MDS, both in CD34-positive progenitor cells and CD4-positive T lymphocytes, leading to improved clinical outcomes. However, in patients resistant to epigenetic therapy, azacitidine has no effect on STAT signaling pathways. So, to investigate the role of ADAR1 in HMA resistance in high-risk MDS, we utilized 41 bone marrow samples from well-annotated patient cohorts, classified according to the IWG 2023 response criteria. With real-time qPCR, we measured ADAR1 and STAT3 levels on CD34-positive hematopoietic stem cells, which were subsequently sorted into specific subpopulations using FACS, including primitive hematopoietic stem cells, late progenitors, lineage-committed progenitors, and erythroid precursors. Additionally, using RNA-seq data from CD34-positive cells, we quantified A2I RNA editing levels in inverted allo elements, whereas transcriptomic analysis was also performed to identify differentially expressed genes between response groups. Non-responders to HMA demonstrated significantly higher pretreatment ADAR1 and isoforms levels in CD34-positive cells compared to responders. As the precise stage of cellular differentiation where HMA act remains unclear, we measured ADAR1 expression across the FACS sorted hematopoietic stem subpopulations, and we found significantly higher levels of the interferon-inducible P150 isoform, only the primitive lin-negative CD34-positive CD38-negative compartment of non-responders compared to responders. None of the other compartments showed any significance different. At the time of relapse after HMA, ADAR1 P150 was significantly upregulated in both CD34-positive cells and early progenitors, suggesting that ADAR1 has a role in secondary resistance too. Of note, early responders showed significantly higher ADAR1 levels compared to late responders, further indicating a potential role of ADAR1 in the immune-mediated activity of azacitidine. In the Kaplan-Meier curve, we see that over time, both groups converge, but ADAR1 low shows longer sustained responses for more patients in the early phase. To determine the functional significance of our findings, we quantified A2I RNA editing levels within the inverted allo elements. And consistent with the upregulation of ADAR1 levels, non-responders exhibited an enrichment of IR allos and increased A2I RNA editing levels events compared to responders. Importantly, the editing ratio was elevated in non-responders, suggesting that the hyperactive ADAR1 activity. The non-responders were also more frequently classified as hyper-edited, supporting the idea that excessive A2I RNA editing may suppress viral mimicry response. The transcriptomic analysis revealed upregulation of receptor of interleukin-6 in non-responders, along with concurrent downregulation of receptor 1 of interferon A and PKR, both known ADAR1 targets, supporting the potential existence of the previous mentioned interleukin-6, STAT3, and ADAR1 feed-forward loop. We further found a positive correlation between the expression of STAT3B and ADAR1 P150 in the CD34 positive cells of all patients, and also marginally higher expression of STAT3B in total CD34 positive cells of non-responders. By contrast, no correlation of the ADAR1 levels with the mutational profile of the patients was found. So, in conclusion, high pretreatment expression of ADAR1, especially the ADAR1 P150 isoform, previously reported as a more efficient editor, is strongly associated with primary and secondary resistance to HMA. In line with ADAR1 levels, increased A2I RNA editing in IRLU elements in non-responders suggest that ADAR1 may contribute to resistance to HMA by suppressing viral mimicry in MDS, whereas the potential interplay between interleukin-6, ADAR1, and STAT3 may represent a novel mechanism of resistance in HMA. To summarize, this work may help to identify a long-awaited predictive biomarker and a potential molecular target for high-risk MDS. Future steps include expanding our patient cohort and validating our findings in an independent RNA-seq dataset. We also plan to assess ADAR1 expression and A2I RNA editing in a cohort of patients treated with combinational therapy, like azacitidine plus venetoclax. This research was supported by the Hellenic Foundation for Research and Innovation, and my participation here was supported by a travel grant from the MDS Foundation. I would also like to thank my supervisor, Professor Ioannis Kotsianidis, our laboratory team, and our external collaborators for their valuable contributions to this work. Thank you all for your attention.
Congratulations. I'm here.
Over there.
Yes.
Hi.
Hi. I didn't see you, sorry.
Congratulations for excellent work. Fascinating, and we really have a problem with the patients after Vidaza failure, obviously. My question, if I got you well, if you suppress the IL-6, it might be effective. Have you tried, for example, you know, even erythropoietin has anti-IL-6 effect or other anti-IL effects? If not, it's a good idea to suggest.
Okay, so if I understand well, interleukin-6 and STAT3 signaling is dysregulated in high-risk MDS.
Right.
And ADAR1 has a positive feed-forward loop with this signaling.
But if you try to suppress it...
Yes, yes, it may be good.
Very nice
Yes.
talk. So basically, is the level of the deaminase, is it just a surrogate for the inflammatory microenvironment?
Yes, the ADAR1 P150 isoform is interferon-inducible, and yes, may play a role in the microenvironment.
And did it correlate with certain genotypes? Did you?
No, we didn't. We didn't check with genotypes.
Can I help? Yes. Actually, ADAR1 suppresses inflammation, so it's not exactly a surrogate for inflammation. It's a very pleiotropic molecule. And also we know that ADAR1 is suppressed from a mechanism via SF3B. But unfortunately, we didn't have any patients with SF3B1. to see what's going on. There's a drug called Ferreiras, which is just about, I think, to be used in melanoma, because it's an immunogenic tumor, and it works through SF3B and suppresses ADAR1. It should be very interesting, but we didn't have any patients, only SFRS2.
So thank you very much for your presentation.
Thank you.
We're moving to the last presentation. Dr. Amer Zeidan will show the preliminary efficacy of Bexmarilimab with Azacitidine in relapsed or refractory MDS.
Good morning, everyone. Thanks for the chairs and the organizers for choosing this abstract, and hopefully everybody enjoyed the nice reception last night, the amazing views of the sunset over this beautiful city. So I'm going to present some data from ongoing phase 1-2 trial looking at this immune checkpoint inhibitor called Bexmarilimab, which I will call Bex for easiness, combined with Azacitidine in the relapsed refractory MDS patients, and these are my disclosures. So Cleaver-1 is actually a novel macrophage immune checkpoint inhibitor, receptor. So this is a glycoprotein that is present on the surface of the macrophages, and data suggests that there is increased expression in patients with cancer and pregnancy. It leads to immunosuppressive microenvironment through the macrophages, and the expression in cancer has been shown to be reversed using this newly developed antibody called Bexmarilimab, which is a monoclonal IgG4 antibody. This will change the macrophages into a pro-inflammatory state and activate the T cells. And in solid tumors, it had been tested extensively and had led to anti-tumor responses. Now, similar findings have been shown preclinically in patients with MDS and AML, where in the myeloid blasts, as well as the monocytes, there's actually increased expression of this Cleaver-1, as you can see in these figures. And this expression is seen on those monocytes. Preclinical data suggested that immune activation happens when you use the Cleaver-1 in this setting. But there's also some interesting data that the blasts themselves express Cleaver-1, and this inhibition could actually interfere with energy production. But this, I think, is still ongoing, and hopefully we see more data on this. So the clinical data that I'm going to talk about are coming from this ongoing phase 1-2 trial. So the phase 1 part of this study, actually, the dose escalation, has been already presented in the past, and the paper is now in press, should be published soon, or should be online soon in Lancet Hematology. But this part of the study included patients with a mix of AML and MDS who were HMA failure as well as frontline. All of those patients were treated with Bex in combination with Azacitidine. They were treated with different doses in a dose escalation schema of 1, 3, and 6 milligram per kilogram. And this data showed that the combination was safe. There was no DLT identified. And you can see in this figure that there were promising responses. So based on discussion with the FDA, we went from this part of the study to what we call the dose optimization, where we looked at the highest 2 dose levels, the 3 milligram and the 6 milligram, to try to better understand what is the best dose to take forward. So this is what I'm going to present today, is on the 20 patients who were treated on this part of the study. All of them had MDS after HMA failure, so there were 20 of them. And you can see the baseline characteristics. The median age was 72, so they were on the older side. Most of them have higher risk disease, as you can see, high or very high by the revised IPSS. Half of them actually were TP53 mutated. So this is a very high risk cohort. In addition, they were heavily pretreated. The median number of HMA cycles that were received were 8 cycles. And those patients were required to have at least 4 cycles or progress on HMA. So this is a heavily pretreated, high-risk patient population. So in terms of the safety that we have seen on the study, the combination, similar to what we saw in the phase 1 part of the study, the combination was well tolerated. Most of the adverse events that were seen were what you expect generally in this patient population in terms of GI side effects, as well as some cytopenias, febrile neutropenia, etc. But when you look at the PEX-related adverse events, generally they were minimal. Only 10% of patients had those that were attributed to Bex, and they were primarily nausea and some leg edema and mild infusion reactions, but there were no discontinuations related to adverse events attributed to PICS or grade 3 or higher PICS-related adverse events. So I think the combination was clearly well tolerated. Looking at the clinical activity, so we saw actually good activity. Again, this is a relatively smaller sample size, 20 patients, but the preliminary activity, in my opinion, is pretty encouraging. When we look at, and I think this is actually a good illustration of the use of the new criteria 2023 compared to 2006, because the rate was higher with 2006, but many of those were marrow CR. But when you look at count recovery, so when you have blast reduction plus count recovery, which what we describe with the IWG 2023, you can see that 45% of patients have meaningful responses. And again, this is an HMA failure high-risk patient population. 2 of those responses were complete responses with limited count recovery. Both of them were bilineage recovery, meaning that 2 of the 3 lines improved. It was not a full CR, but very close, which I think, in my opinion, again, is clinically very meaningful. 1 patient was CRH, partial count recovery, 1 patient was PR, and 5 patients were HI. So I think there's clearly evidence of activity that we are seeing here. And this is further supported by looking at these waterfall plots for blast reduction. So most of the patients in the study, 11 out of the 20, had at least 50% relative reduction in the blast count. And you can see that there was also a trend that patients who had higher expression of cleaver-1 had higher reduction in their blasts, supporting the mechanism of action of this antibody. And the median survival, again, this is a relatively limited sample size, but the median survival after HMA failure, we know from previous data, is around 6 months for most patients. In some more recent data, like the on-time study, it was around 8 months, but 13 months is, I think, is in my opinion, is quite promising. 4 of those patients were able to go to transplant. So I think the survival also seems to be supportive of the efficacy of this drug. Another, I think, good efficacy point to look at always is transfusion independence. And out of those 20 patients, 14 of them met the definition of transfusion dependency over the last 8 weeks. As you can see here, most of them were platelet transfusion dependent and red blood cell transfusion dependent. And of those, 3 out of the 14, which is 21%, achieved transfusion dependency, transfusion independency for at least 56 days as defined in the response criteria. When we look at evidence of pharmacodynamic evidence of activity, we are seeing evidence of immune system activation. There was increased expression, HLA-DR expression. There was increased infiltration by the T cells, suggesting that the antibody is associated with increased immune activation. Of course, this is limited by not having a control arm in a single arm study, but I think this data is supportive. And I mentioned this earlier, but also I think the trend in terms of association between cleaver-1 expression and the reduction in the blast and the response seems to be there. I think this is something we are going to explore further as this study continues to advance. Now we are actually, we have studied patients in the frontline setting as well as more patients that you are seeing now in the refractory relapse setting. And some of this data actually will be presented in ASCO and IHA. There will be a lot of updates on this data. So in summary, this combination of Bex with azacitidine was well tolerated. There were no grade 3 or higher PICS-related adverse events, no discontinuation related to PICS. Around 45% of patients achieved objective responses by the IWG 2023 criteria, and there was evidence of blast reduction in the bone marrow as well as evidence of pharmacodynamic activity with immune activation and association with cleaver-1 expression with the responses and the blast reduction. And we look forward to providing additional updates in the next meetings about the activity of this very interesting combination. And with that, I will conclude and happy to take questions.
So, thank you for your interesting talk. So is the antibody working on the healthy or on the diseased monocytes, macrophages?
I think it's, we think primarily on the monocytes, but as I mentioned, there's some evidence that it might have activity at the level of the blast, on the cleaver-1 expressing blast. This is still being studied further.
But on the health, so the monocytes derived from the diseased clone or the monocytes?
Oh, I see. I don't think we have evidence clearly for that in terms of where are the monocytes. I mean, I would assume they are disease-related, but we have not done like specific kind of analysis. Look at that.
Is the expression higher in certain genotypes, and how is it compared to normal of the cleaver-1?
Correct. Although again, this is indirect because this is a single-arm study, so we only have patients.
We have a question over there.
Hi, Andy Bruder from Boston, US. Amer, great work. Very interesting compound. Interesting strategy, too, to do a combination in the progression state. I guess I was just wondering, do you have a sense of how many patients went straight from his HMA-type regimen to this versus how many patients had a period off of HMA? Are you mostly salvaging lost response but continuing azacitidine, or is this kind of more of a people have relapsed after a time off? I don't know if you have that data, but just...
Yeah, no, I'm sure we can find this out. I don't have that exact number, but what I can tell you is that those patients were heavily pretreated, like the median cycles were 8 cycles, but I don't know how many of them kind of were directly primary refractory versus secondary failure, but it should be easy to dig up. We can find that and provide it to you.
Okay.
Sure.
Amer, and apart from cleaver-1 levels, did you find any genetic marker suggesting a better or poorer responses in these patients? Probably you have mutations data.
Yeah, so half of those patients had TB53, as I mentioned, which is, again, I think this speaks to how often we find TB53 in trials because everybody's trying to kind of find a good option to treat them. And the responses we saw in those patients were reasonable. Again, I always hesitate to make big conclusions from a relatively small data set and a subset, but I think that the responses we are seeing are looking good, especially, again, if this survival holds up as we kind of treat more patients, I think this would be very encouraging. And I cannot speak right now about the data in the front line, but I think the front line data that will be presented in subsequent in IDHi, I think, is also supportive.
And regarding the next steps with this drug, it seems that cleaver-1 expression is important. There is an easy way to measure it before entering patients in trials, because we learned that entering all the patients in the same trial perhaps is a problem to identify a good responder or not. And are you working on that?
Yeah, I mean, I think there is certainly some association. I think the problem is when you try to include that as part of the trial eligibility, it becomes much complicated because you have to develop an assay that regulators approve. And I think we are seeing like generally good enough responses that I think we can go without specifically requiring that. But I think trying to look on this within the context of the trial and developing the assay further and understanding this association better is certainly something we are doing. So in terms of where the trial is going, we are discussing with the regulators at this point about the next steps in terms of how do we build up on this trial and hopefully taking it to a more advanced and randomized setting soon.
So thank you. If there is no more questions, I think that we can close and move to the next section.
Thank you so much.